Please remember to utilize the parking lot. If you do have additional questions, we will try and get those answered for you. You should have Post-its on your table, and then just make sure to take them over to the parking lot so that we can address them. We are honored to introduce our next speaker, Stephanie B. Broussard, a licensed clinical social worker, supervisor, an advanced certified hospice and palliative care social worker, a certified advanced care planning facilitator, and trainer. Stephanie's passion extends beyond her professional roles, recognizing the profound impact of life's transitions. She has made it her mission to share intentional, powerful messages about purposeful living. Please join us in welcoming Stephanie to the stage.
Hello, how are you all? I'm so glad to be here. Let me start my timer because I love the sound of my voice, and so I just get out of control. And then also, someone was gonna get me a clicker, or am I just gonna say next slide? Whatever works. Thank you so much. All right. So, as mentioned, I'm Stephanie Broussard. I have the luxury of being the director of palliative care and social work at Texas Oncology. And it is a space that it's extreme honor, number one, to be here with you guys. But I take no moment lightly that I am able to share time and space with people who are experiencing cancer and living through it and surviving or supporting or caring and advocating. This group is powerful. You are a fierce group of advocates, and so I'm so honored to be here. I believe the last time I was with you guys was 2020, and it was a very different context. We were in the height of, I believe, the pandemic, or had just kind of settled in. I can't remember exactly. And so I'm so glad to be here again. But last time I was here, I talked a little bit about advanced care planning and the power of conversation and the power of setting our goals of care. And of course, that's a really important part of palliative care. And so we're going to talk a little bit today about what that looks like um, in the face of cervical cancer and even a little bit about hospice. And so I want to just kind of preface the conversation. People are like, oh, the lady's coming to talk about palliative care and hospice. First, of course, this is a space that I believe is powerful and impactful. I also hope that we can change the narrative of what this space looks like. So this is not a doom and gloom conversation, although it may be tough, and we're going to have some honest conversations, and hopefully we can ask and answer some questions. But the reality is that I hope you leave with a different perspective about what palliative care may be for you or those around you, okay? So what's palliative care? Okay. The reality is that palliative care is a discipline and a specialty dedicated to treating total pain. And so we're going to talk about that a little bit. Total pain is the idea that we don't just suffer or have pain that is physical, but we have emotional distress, emotional pain, psychological pain, even spiritual, existential pain and suffering. And so, in order to really treat the idea of total pain, even the system that supports us, whether it's our family, primary caregivers, their experiences, their suffering that may be as a result of the illness, is also part of that concept. And so, really, to treat total pain, we have to figure out how do we do that that's interdisciplinary and a perspective that covers all. And so we're going to talk. I have these slides. I usually don't use slides, but I was like, they may need something to look at, outside. I'm cute, but outside of me. So palliative care has a little bit of a branding problem. Okay. People think and they hear palliative care and I'm ready to like, it's not time. I'm not ready. Okay. The reality is that palliative care is not this. We are not the Grim Reaper. Okay. If your provider or someone that is a part of your care team comes to you discussing palliative care, we are not trying to take something from you. We are trying to add to your care team. We're trying to add to your treatment plan. We want to add this element in perspective that there is a way to treat total pain in addition to the care that you're already receiving. Okay. So there are a few myths, and I want us to play and talk back to me. I'm a Southern girl. I'm from Louisiana, but live in Texas. But I'm also the granddaughter of a Baptist preacher, okay? And so if you know anything about Southern Baptists, they like to hear amen and have people talk back to them. So I want you guys to engage with me just a little bit. So the first myth, or is it, palliative care is only for patients at the end of their lives. True or false? False. Yes, class, false. False. Palliative care and hospice are the same type of care. False, but actually, hospice is a type of palliative care approach, right? We're going to talk about that a little bit, the differences, but hospice uses a palliative care philosophy, but they are not the same. If my doctor refers me to have palliative care, they've given up on me. True or false? Oh, I lost a few of y'all. But it's false. It's false. Remember, palliative care is a supplement, it's an additive. We're looking at how do we make sure that all of you is cared for. We're looking at the functioning of your quality of life based on your definition. And so we're gonna learn a little bit. That was a lot of spinning. My oncologist will no longer manage my treatment plan if I'm on palliative care. True or false? False. Your oncologist remains your primary provider. So even the tough part about palliative care is even some clinicians have a misunderstanding about what palliative care is going to do, what we're going to add, where the value add is regarding palliative care. For oncology patients. And so a lot of places, even my own practice, as we continue to advocate for the need of palliative care and expand it, not all patients maybe have access to palliative care in the same way. And so as we continue to advocate for access to palliative care, of course, my personal perspective is that every person that is diagnosed with a serious illness should have access to palliative care. But of course, I don't run things. But that's the reality, is that there's benefit for every single person that has a diagnosis of a serious illness or life-limiting illness, because there's value there. It may not all look the same because, of course, we want to make sure that the services are appropriate, but palliative care is necessary and effective for any person living with a life-limiting illness or a serious illness. So what's palliative care? We're going to dive in. So it's a specialized medical care for an individual living with a serious illness. And it's specialized because it is person-centered. Rather than us tell you what we think it is for you to live without a symptom burden, we ask you, what's your quality of life? What's most important to you? What gives you joy? What are the functions that are primary to you living your life on day to day? What are the specific abilities that you think are really important for you to try to maintain and highlight to maintain your quality of life? Now, we're also realists. So we have a lot of tough conversations because there are some things that we're not able to alleviate. But if we're not able to alleviate it, how do we minimize the symptom burden, okay? And so it's specialized, it's patient-centered, it's individualized. Your care plan won't look like your care plan. It's really based on what's important to you. And then it's really focused on quality of life. And it's really, really specific about what quality of life is to each individual. If I see 5 patients in the day, and of course, I don't think I shared this, but I'm a licensed clinical social worker. So what I do on the palliative care team, except for be the director, is also to provide psychotherapy for the emotional and impact, whether it's PTSD, depression, anxiety, exploring mortality, legacy building, but the emotional impact of living with the disease, okay? And so that's where I come in addressing that emotional, psychosocial burden. And then there's some members of my team that may address the psychosocial toxicities of cancer, meaning we're talking about the financial, practical things as well, okay? And so when we're looking at quality of life, we're looking at all those things, everything that encompasses you, but how do we make sure that quality of life is maintained? And then we're looking, I have my slides right in front of me. I don't know why I'm looking behind me. I'm sorry. We're also looking at what does it really mean for you in regards to when relief of those burdens. So for example, we may bring in other members of other teams to support that. So an interdisciplinary team for palliative care at standard is a palliative care physician or a nurse practitioner or a physician's assistant that's specialized in palliative care, a nurse, a social worker that specializes in palliative care as well, and then a chaplain, and then also specializing in palliative care. And so that's our core interdisciplinary team if we're going to do comprehensive palliative care. But that also may look like, for example, if we have a patient who is experiencing cervical cancer, her team for us may also look like we can collaborate with her pelvic floor therapist or a sexologist to bring in to make sure, because total pain to her may look different than total pain to somebody with lung cancer. Okay, or it may look like us bringing in occupational therapy or complementary therapies or acupuncture or those kind of things, because remember, it's patient-centered. And it can vary based on the access to those complementary services we have access to, right? Also, in addition, it's really appropriate for any patient at any age, at any stage. And that's where the conversation gets a little tough, because the reality is that for some people, not only is it a barrier to palliative care, the access and availability of comprehensive palliative care, but it's also payment models. Okay, because the reality is that we can't get care sometimes because number one, our insurance won't cover it. Who's it available to? And so a lot of programs may have shifted downstream to where we see patients who are at later stage of disease because they have a higher symptom burden, and we're trying to manage that. But that doesn't mean that's only who's appropriate for it. And so that's where it gets confusing because people may operate at later stage because we see that heavy symptom burden, and insurances are more likely to have their programs that are specialized that cover additional services for those patients that are at later stage of disease. Also, we want to make sure that it's also important for you guys to understand that palliative care isn't something that you have to wait for your provider to offer. Okay. And so a lot of times I hear people, they'll call me or they'll see, because they'll see, Google, you're looking in your area. Even our own patients that are served by Texas Oncology, they're like, well, I went to a conference, I read about this palliative care thing. Why hasn't my doctor offered it to me yet? And so sometimes there's still the uncomfortability, whether it's through clinician or the patient, because we hear palliative care. You remember that branding problem. And so even providers sometimes are resistant or hesitant to offer palliative care early on because they don't want patients to lose hope. We don't want people to think that we're giving up on them. And so that's why it's really important for us to change the narrative all around for all of us and to educate the public and you all about the importance of access to palliative care and the benefits. There's even evidence that patients who have access to palliative care early on have better outcomes. And so we really want people to have this access and supportive services. So when we think about palliative care, this is not mine, and I borrowed it, and for some reason my citations aren't showing up, but palliative care looks at the body, the mind, your social needs, your spiritual needs. What does it look like for you to live well daily? And then your desires and goals, and ultimately your illness. And it's saying, how do we take care of all of this for you? Meaning in collaboration with your oncological team and making sure that we have a plan in place to address those things. And so sometimes people think palliative care just is pain management. It's total pain, but it may not just use pharmacological or medication interventions to address that pain. Okay. And so that may mean sometimes we have sessions where we're talking about managing your breath and learning how to control that, or using PMR when you're having some pain in settings where you're not able to remove yourself, but making sure that we can use progressive muscle relaxation to re-engage your body and help do some of those things, or the power of meditation, or those kind of things. But each member of our team is there to really alleviate that. And so I just like that graphic. So I'm also here to talk about hospice, okay? Palliative care and hospice are not the same thing as we mentioned before, but they are both very important services. We use the same philosophy, which is the idea of treating total pain. Palliative care and hospice are the very few disciplines and specialties that say it's not enough for me to just take care of you. I have to also take care of your system. So services are offered to your family or primary caregiver as well. But hospice is where the focus is also on quality of life, also symptom burden. But the difference is that it's for individuals who have a terminal diagnosis and are no longer pursuing aggressive treatment for their primary diagnosis. So a lot of times that means that, for example, if I have decided to no longer forego any radiation, any chemotherapy, and I am at the point where I am no longer trying to aggressively attack my disease. I know the fight language can be a little, controversial, but the reality is that people think hospice means I've quit and I'm no longer fighting. And I don't believe that's the case. I believe we have just switched opponents. When a person selects the option to pursue hospice care for themselves, what I believe happens is they are saying, you know what, cancer can kiss my ass. Excuse me, I cuss a little too. But at this point, my opponent now is my fight for my quality of life. I may not know how many days on a calendar I have. I may not know how many times I'm gonna see the clock spin around. But the time that I do have, my focus is on quality of life and minimizing my symptom burden as I define it. I believe that's what it means to select hospice. Okay? So for those who are like, they quit, no, don't come to me with that. That's not it. Okay? Hospice is also a very vulnerable and powerful choice when we're having to make it. But when I see people and we're exploring mortality, one of the things they struggle is how to know when. That's when I believe advanced care planning is so important, because my patients that I see, whether it's the start of disease or in the middle, and we're exploring mortality as things change, is we talk about what are the deal breakers. And that's not a conversation we have when we're suffering. That's a conversation we try to have early and often to talk about, you know what, how do I know when I've reached this place where I've done all that I am willing to do in aggression and fighting this disease? Or when has my quality of life been impacted enough that I'm like, you know what, I'm not doing that anymore. And that's also a very powerful decision. Okay. And so when we think about hospice, it's important for us to know what it is. Okay. So hospice is the focus, as I mentioned, on quality of life and symptom burden for those with a terminal diagnosis. In order for a person to be on hospice, they have to have certification from a physician that they're actually terminal. Okay. And it's not like you go on hospice, they're going to take you out in 6 months and that's the plan. Okay. That's not how it works. It's reality saying that by science and evidence, you have a prognosis of 6 months or less. But there are people who can be on hospice much longer as long as they're continuing to decline. Okay. Or they're no longer receiving aggressive treatment for a disease that is a degenerative disease. Okay. So I've seen people on hospice much longer. I've even seen people put off hospice where because their condition has improved, they no longer meet the criteria. Okay. So hospice is also, hospice, what defines what hospice offers currently in the US is defined by CMS or Medicare. Not that hospice as a scope, but hospice as the benefit, okay? And so that means every patient who's on hospice has to have access to an interdisciplinary team. That's a physician, and usually the visits are done by an APP, but the physician who certifies an APP to do their check-in month quarterly visits, and then a nurse that sees them based on their treatment plan, and then a social worker that sees them based on their treatment plan. And then some have access to aides to help with activities of daily living like bathing, dressing, those kind of things. And then a chaplain. Because remember, it uses a palliative care philosophy to take care of total pain. So also what happens is, I just realized I set my timer backwards. So somebody please flag me down. Oh my gosh, I can't believe I did that. I was like, what's happening with the time? Also, what happens with hospice is that there are also additional services and supplies that can be offered, and I'm going to talk about that a little bit. But it's not just for older people. It's not just for people who are, saying they don't want to do anything. It actually also is treatment. It is a treatment of the symptom burden. So there's medications, there's different things that are provided as well. And the scope of services can be dependent on the hospice. For example, one of the hospices that I use for my patients, they can also still have paracentesis or those kind of things based on need, okay? And so people think I go to hospice, you get nothing. Actually, that's not the case. So what's the difference? And I'm going to actually look at this. Palliative services are paid by most insurances, or even we have some patients that self-pay for certain components because their insurance won't cover it, which sucks, but that's just reality. It's appropriate at any stage of disease, and it can be provided at the same time as curative treatment. And it's also available in various settings. So there's home palliative care teams, there's palliative care teams that are offered in the clinic, palliative care teams that are in acute, like the hospital, where I spent most of my career. And then we have hospice. Hospice is paid for, my head's big, I'm sorry. Hospice is paid for Medicare, Medicaid, and insurance. Of course, the prognosis is 6 months or less. It excludes curative treatment, but for the admitting diagnosis only. So say, for example, I have congestive heart failure, but I also have cancer. I can still receive curative treatment for my congestive heart failure if it's not related, the symptom burden, and be on hospice for cancer. Doesn't mean I have to stop seeing my cardiologist, okay? Also, if you're on palliative care or hospice, you can still see your med-onc, okay? Hospice as well. People think if I'm on hospice, I can't see my med-onc. Actually, you still can. And then hospice is provided wherever a patient calls home. That could be your home, your friend's home, the nursing facility, assisted living, even unfortunately a homeless shelter. And where they're same is that they both offer comfort care, right? We're reducing stress, we offer complex symptom relief, and then of course, psychosocial and physical pain. So when we think about care, a lot of times, especially in healthcare, it's kind of like, we'll do everything the same for everybody because one size fits all. And that's not the case. With hospice and palliative care, the focus is really on care dictated for you. And hospice, more so than anything, it is really saying you drive. You help determine the care plan. You are a member of the care team. Your caregiver is a member of the care team. And we have really specific conversations when a person's on hospice about what is it that's important to you? What do we want to do? And so we have conversations like, for example, when my grandmother was on hospice, we talked about for her, eating was really important. She loved food. Well, she was risk for aspiration pneumonia. And we talked about that that's a risk we're willing to take because for her, that's quality of life. Okay. And we had those conversations about what is the burden and how do we manage the risk of comfort and the risk of, whatever that side effect is going to be. And we let you set the scales. The same with pain management. I have some patients who are like, I just want to sleep this thing away. And then I have some patients who are like, I need to be as alert as I can be. So their focus is how do we keep them as comfortable as possible, but as alert as possible. And then some patients are like, I'm just sleeping on out. So the comfort is primary, okay? And it's also important to understand that some of the medications can be used. I have conversations with probably almost every family that we refer to hospice about morphine. Because they automatically assume if you give my mama or you give my sister morphine, they're gonna die. We know that's not the case. We don't rush anybody out. Now, there are options for death with dignity in some states, which I encourage if that's your pursuit and your desire, that you consult providers to help make sure you can get there, and there are a lot of resources to do that. In Texas, it's against the law, but my job is to make sure people have access to resources. Okay? And so really exploring what those options mean for you. Okay? And it's really about control. It's really about you having the power to say so in a situation where there is very little. Okay? And so I think a lot of times when we think about how hospice comes into play with care, it's really about you saying what it looks like for you, the when, the how, the where. This is one of my favorite quotes. It's in my office. You matter because you are you, and you matter to the end of your life. We will do all we cannot, only to help you die peacefully, but also to live until you die. I believe that dying is part of living. And unfortunately, we live in a society where we don't want to talk about death. Everybody's dying and nobody wants to talk about it. I'm dying as you look at me, but I am living, right? If we don't talk about death in that context, then we keep it with this veil. We keep it with this fear and this tone that can be impactfully harmful. Having conversations that are important about our quality of life and what's important to us empowers us, but it also is a gift of love to those around us, the families that we may leave behind. Okay? It's saying, even if I'm no longer here, how do I make sure that I can't remove your grief? You may always have grief, but how do I make sure you're not layered with guilt? How do I make sure that you understand that what you did or how you cared for me was on my terms and you helped to empower me to even do that? How do I make sure that they feel like they've made decisions that are in line with what was passionate to me? And it's tough to think about. I'm not trying to put a rainbow or a bow on hospice and palliative care and be like, yes, let's smile about it. But I do believe it is still a beautiful experience to be able to engage with families and talk about how do we care for each other, even in the face of serious illnesses like this. And it's kind of like insurance. We all get in a car and maintain our insurance because we don't know what'll happen. I hope none of us for a long time are faced with this, but the reality is that some of us may be. And so if we have conversations that are important and intentional, it empowers us and it can embolden us too. And it's about control. If you always remember, it's about controlling the uncontrollable. Okay? And so I know it's a little heavy to think about, it's a little heavy to talk about, but I think it's really important that we look at the ideas of how do we use palliative care and engage it early and often as a means of navigating life and living? And how do we kind of put that idea of what hospice is in our back pocket if we were to ever need it and not be afraid to engage when we do? Thank you, guys.
Thank you so much, Stephanie, for joining us. If you will have a seat while we listen to a brief patient voice. It is an honor to introduce our next speaker, Lorie Wallace. Lorie is not just a 6-year cervical cancer survivor. She wears many hats in her mission to make a difference. As a cancer patient advocate, speaker, and support coach, she extends her knowledge and support to those facing the challenges of cancer. Please join me in welcoming Lorie Wallace.
Thank you and good morning, everyone. So if you see, for those who don't know me, if you see me with a cane, I am completely healthy. But I will get into why I use my cane. So thank you for the introduction, Christy. I'm just going to jump right into it since you all know who I am. In 2017, I went into surgery for adenocarcinoma. I was told that it was endometrial. I went in for a full SP. I went in there childless. I went in there childless, wanting children. I was in my early 40s, well, mid 40s, but my periods had stopped for some reason. And I thought, you know, at least if I still had everything in here that's me, made me a woman, I'm still in the sandbox. So when they called me on the phone to tell me that you had cancer, they said everything has to go. So I'm a fix-it type of person. I leave my anxiety attack for another time and I get down to business because I know that there wasn't a lot of time. You have to move, you got to get it done. So I had everything removed and I received a portal message that said, alert, alert, alert. And that was pathology. Why is there an alert on my pathology? Why is it coming to me? And I had many years of research. So I went to the right sources and I said, I'm going to have treatment. And I did. So after all of this was removed, I would have to have the high dose radiation along with the chemo. Right now, to answer the question, why does Lorie have a cane? I started falling in 2019. And when I mean falling, I didn't trip, I didn't slip, I didn't stumble. I collapsed. And when I collapsed, I would collapse on my knee and I would bust open my knee. No one knew what was going on. That stopped. It didn't happen again for another year. Then it started happening. So only recently, I say within the last year, I was diagnosed what they believed was plexopathy. And they confirmed it recently with an EMG. So I have chronic denervation of the muscles in the legs that are associated with L2 through 4. I'm going to give you just a real quick understanding of what plexopathy does and why it is a traumatic diagnosis. No one knows what your nerves are going to do. So plexopathy can do three things. It can start, and it can just start taking everything out in that area. It can start and it can stop and it can come back, or it can start and it can stop. So they don't know. I'm not going to end up in a wheelchair because I said so. So I use this not when I walk around here. I use it when I walk up the stairs and outside. And I said it, and so it's done. So I've used these years since diagnosis, since surgery and treatment, to use my pain and my advocacy. I also use the fact that I have been a caregiver since I was a child. I had helped take care of my grandmother who had dementia, and that included from childhood to my teens, changing her diapers, feeding her, giving her her meds, being in a bedroom above her where she was screaming nurse, because I didn't want my mother to have to get up in the middle of the night and continue to do it. She had painful osteoporosis. I would have to go on to co-care for my mother, who was my best friend, who also had dementia and bladder cancer. When she passed from hospice, I held her in my arms for 30 minutes while I could hold on to as much warmth as I could. Once that was gone, I got up and I left because I knew that she was here. I took that journey and I said, what is missing? We have all of these wonderful, resources. We have doctors, and someone had mentioned, before, gosh, when I had treatment or surgery, I didn't have the nurse navigator, I didn't have the NP, I didn't have the PA. We have those. So I'm an Immerman Angel mentor. So I mentor people all over the country, but people found out about my story in Metro Detroit. And I personally take care of people, not mean take care of, I mean, I will hold their hands as they end their journey. I hold their hands as they go into the doctor's office and they want to ask questions. They're getting their diagnosis. They don't know how to talk to their doctors. Why are they calling me? There's all of these resources. Why are they calling me? Because people don't get it. You understand what it's like because you have the data. You understand the treatment modality. But I had a few patients say, they're telling me I'm dying. They're talking about death. I don't want to talk about death. I want to talk with you. Or my family doesn't understand. They don't understand cervical cancer. I want to talk with you. I don't want to talk about how does it make you feel? You know, how does this, I don't want to talk about it. I want to know why my vagina feels the way it feels. I want to know why I'm having these symptoms. And sometimes maybe my care team is saying, well, that's rare. It doesn't matter if it's rare. It's happening to you. If you're 1B1, you're 1B1, and you're 1B1, and we have all of the same treatment, you still are bringing different luggage to your care. Life could have been, what did they say, and as good as it gets, noodle salads and lake houses. Some people could have lost everything when they went in. You don't know what a person goes through when they enter that battle. So that's where I come in, and perhaps that's where all of you can come in. It's important to me because I'm still here. So as far as I'm concerned, I'm morally obligated to make my life count by helping someone else who's going through hell. And they want to look at someone and they want to know that I get it. I may not know what it's like to die, but I get it. So one of the last patients I took care of, her family had called me over and they said she's in the process of dying. And her father wanted her to try the Orgain shakes that I brought about a month prior. And I said she could aspirate. I said, but let's pretend. So what I did is I took the straw, but I kept it blocked and I held it up to her mouth so that she wasn't getting anything in there. So I made him feel like he was a part of the machine. He had some say. I looked at her and she just wanted me to hold her hand. So I held her hand and I sang to her. I got a call the next morning that she passed. And they said, thank you for the beautiful end of her life. And as an empath, I've learned to not, an advocate, and now as a cancer coach, I've had to learn to pull some of that away because I can't continue to help others if I am holding on to that pain myself. That's not my job. So we're going to sit here and have a discussion. I'd like to open this up before we go into a Q&A. If you're comfortable, can I see a raise of hands? How many of you have ever had to deal with a loved one or friend in hospice? And we'll go on to our Q&A.
Lorie, we do have a virtual question. Somebody simply wants to know, how are you doing now?
How am I doing now?
Mm-hmm.
Well, I have colitis from the cisplatin. I have what's going on right now. There is a huge stigma with cervical cancer, but there's a huge stigma with this. I've had almost 20 years of a very intense martial arts. So you're talking to someone who's very proud, and I don't want to hear about what they say in the Bible. I get it, but I'm proud. I'm very strong, but I hurt. I hurt emotionally, physically, and spiritually, but I admit it. So I'm going to try to make a way with in my day-to-day. I don't use this cane in the house. I need it to go up and down the stairs because that's when it activates those nerves, or it doesn't activate those nerves. And I'm going to try it. I'm lucky enough, and this is something else, the further we're getting with treatment, the longer patients are living. So doctors are going to start seeing people with these plexopathies. So your oncologist may not be able to help you because it's not in their wheelhouse. Am I correct? But I'm fortunate enough to have one of 60 doctors in the United States through the University of Michigan Local Cancer Center who deals specifically in oncology, rehabilitation medicine. And this is precisely what they do. So my modality would be antioxidant with a higher dose of vitamin E. There is a medication that's new. The problem with that is if you start it, you stop it within 3 months, you're okay. If you take it any longer, then it can actually cause the plexopathy to get worse. My question to him was, let's go with the vitamin E. Let's go with the alpha lipoic acid. Let's see if there's any changes. So thank you for that question. Day by day.
There is a question for you, Stephanie, as well. How do you get a referral to palliative care?
So ideally, in a perfect world, your med-onc is referring you to palliative care once you're diagnosed as part of your treatment plan. Unfortunately, probably for most people, they may have some centers have triggers where, based on symptom burden or decline, there's something that causes an automatic referral to palliative care. But for most people, if your provider isn't referring you to palliative care, then you need to ask. And there may be a reason why they've delayed it, or maybe there's about an access issue. But really, your med-onc or your primary treating oncologist should refer you to palliative care. We even have PCPs that can refer to palliative care as well, depending on what's going on.
Thank you so much. Thank them both, please, for their time. Please remember again to utilize the parking lot so that we can get your questions addressed. I'm sure if you have an important question, we definitely want to take care of that for you. We're going to go ahead and take a very quick break, and then we will move on to our next panel. Thank you. Please remember to stretch, use the parking lot, and go shopping.
These shoes, I didn't even see them when you came over to me. You showing that.